All right, so I'm going to take up a presentation on the anatomy of the bony pelvis. So I'm Lawrence Achapon, and it's good to have you guys around. So at the end of today's section, we should be able to know about the bony pelvis, its component parts, clinical importance, and all that. That's what we're going to talk about. We know some basics about the bony pelvis already, but let's talk about it today, alright? So that's what we're going to focus on today. So this is the bony pelvis we are seeing here, and you will notice that normally the pelvic region is found inferiorly and posteriorly to the trunk. What make up the trunk? The thorax, the abdomen, the pelvis and perineum, and the back. Alright. So it's found in the inferior and posterior aspects. It's inferior and posterior to the abdomen. Why? Because you have some viscera that are lying here. You know, there are some viscera that will lie on this greater pelvis, right? Like for example, you will find your small intestine around this region. You find something like your sacrum, your appendix around this area. You find things like your sigmoid colon around this area. All right. So there are structures, and if you notice, your abdominal wall, it extends to this brim, the brim of this pelvic girdle. All right. So the pelvis is said to be inferiorly and posteriorly to the abdomen. All right. So it has two parts. The pelvis has two parts. It has this part that is superior to this pelvic inlet. This is the pelvic inlet. So this part superior to this pelvic inlet is called the greater pelvis. All right. And the part below it is called the lesser pelvis. So what's the role of this greater pelvis? The role of the greater pelvis is to house those lower abdominal organs. It protects those lower abdominal organs. As I said, there are some viscera of the abdomen that will lie like the ileum itself. That is the small intestine, right? The small intestine will lie here. Part of the small intestine will lie here. That's the ileum. Then you find your appendix, your sacrum around there. You find your sigmoid colon around there. All right. So this structure, this greater pelvis, tends to protect those lower abdominal organs. Then your lesser pelvis, the role of the lesser pelvis is majorly to house the pelvic viscera. So within the lesser pelvis, you're going to find the major pelvic viscera consisting of organs of the urinary system, the organs of the reproductive system. That's what you're going to find in the lesser pelvis. All right. So what are the relations of the pelvis? Anteriorly, you're going to find your abdomen. Then posterolaterally, what you find is the gluteal region. All right. Around this area, you're going to find the gluteal region posterior and laterally. Then inferiorly, you find your what? Your perineum. Around that. All the shape somehow basin shape, right? It's a ring of bone. Is basin shape, and what it does is to connect. It connects the axial skeleton above with the lower appendicular skeleton. So the axial skeleton, you're going to find the lumbar vertebra above here. Then you find the femur here attaching, articulating with the acetabulum of the pelvic girdle. All right. So what it does is to connect this axial skeleton above with the lower appendicular skeleton. You get. So there are functions that this pelvic girdle perform. One of the functions is weight bearing. What weight does it bear? It bears the weight of structures that are above it. Alright. You know that we have the abdominal organs above it. For example, you have your thoracic diaphragm. What does it bear? It bears the weight of the thoracic structures. Alright. This pelvic girdle, you know, there will be a pelvic diaphragm at this lower end of the pelvic cavity. So what this pelvic girdle does is to bear the weight of those structures that are above, those structures of the abdomen, those structures of the pelvic girdle, that's the viscera and the rest. It bears the weight of those structures, even the bones. It bears the weight of structures that are above it. That's one of the functions. Another function is transfer of weight. What does it transfer? It transfers the weight from the axial skeleton, which is above it, down to the lower appendicular skeleton. Alright, so that's the second function. Another function of this pelvic girdle is for delivery. Alright, another great function of it. It also houses some pelvic viscera here in the lesser pelvic region, the pelvic cavity found in the lesser pelvis. It houses those viscera there. Also, it provides attachment. When you talk about the external genitalia in males, it usually provides attachment to the external genitalia here. Alright, so these are the major functions of the pelvic girdle. The question now is, what bones make up the pelvic girdle? We have been looking at this picture and we will not be able to talk about these bones here. If you notice, you see this bone here. This is called the sacrum. This is one of the bones making up the pelvis. Then you have this bone here, which is fan shaped. It looks like the hand fan usually is, right? This is called the hip bone. There are two hip bones, the right and the left hip bones, and you have your sacrum. These are the two major bones, alright, but you also have the coccyx here. But the two major bones that are identified as bones of the pelvis are the hip bones and the sacrum. Alright, so let's talk about each of these bones in details. We're going to start with this first bone, the hip bone. So this is the hip bone. I don't know if you guys can still see my screen. I'd like to know if you can still see my screen. Just please write me down in the chat box. Alright, perfect. Thank you very much. Alright, so this is the hip bone here. This is the lateral view of the hip bone. And then you notice it's colored already here. There are three parts of the hip bone. Alright, there are three parts. There are three separate bones that make up the hip bone. Usually joined here at this layer by a cartilage called the triradiate cartilage. Usually running in a V-shaped direction. Alright, but at adulthood, these bones they fuse. Alright, so this one is called the ilium. Right, this is called the ilium. Alright, then you have this bone here called the ischium, and then you have this one called the pubis. Alright, so you have the ilium, the ischium, and the pubis. We're going to talk about the details right now. So this is the lateral view and this is the medial view. Alright, so we're going to look at the medial view and describe each of these bones. Let's start with the ilium. From this ilium now, you will notice that it has on its medial aspect a foci here, a depression here. This depression here is called the iliac foci. Alright, then it has a ridge superiorly above it. Alright, this ridge is called the iliac crest. This iliac crest continues anteriorly to form a spine, which is not too prominent here. Sharp pointing projection here also called the posterior superior iliac spine. Alright, then inferior to the anterior superior iliac spine, you're going to find the anterior inferior iliac spine. Inferior to the posterior superior iliac spine, you're going to find the posterior inferior iliac spine. Alright, so this is the crest. The crest has two lips, as we know, inner and outer. So if you notice here, the ilium has this area here that articulates with the sacrum. The sacrum, it articulates with the sacrum to form the sacroiliac joint. This is called the auricular surface, iliac tuberosity that articulates. So these two structures, this iliac tuberosity and this auricular surface, they articulate with the sacrum to form the sacroiliac. Another thing we need to take note of from this medial view is this very important structure here. Alright, found here, called the aquate line. Alright, because this aquate line with another structure here, which we are going to talk about soon, we form something called terminal line. Alright, so we've talked about the ilium right now. Then if you notice from the lateral view, you see that the ilium is somehow convex. Here is concave depression, there's a convex depression here, and there are what? Ridges here. Alright, there's something I didn't make mention of here, that the ilium is divided into two parts. It's divided into this upper part, this wider part called the ali or the wing, and this part called the body. Alright, so this body usually forms the superior part of this acetabulum. Alright, so that's what this body forms. Now let's move on to this next bone here called the ischium. Alright, so the ischium usually is found in posterior lateral direction. It's pointing posterior lateral. Right, it has two parts. Alright, it has a body and it has a ramus. Alright, it has a body and it has a ramus. So what are the important features of this ischium? It has this opening here called the ischial tuberosity, and usually a spine here. Alright, I think this is better. Alright, this is better. So this is what we're talking about all this while. So we are here now, we are in the ischium, right? You will notice that it has what? A body. This body is forming first. It's forming the posterolateral aspect of the acetabulum. And then you have these two important features of it, the ischial tuberosity and this ischial spine. Then there's something I want to make mention of here. Between this posterior inferior iliac spine and this ischial spine, you have a notch here called the greater sciatic notch. Alright, and then between this ischial spine and this ischial tuberosity, you have a notch here called the lesser sciatic notch. So I think these are the major features that are here. So now let's talk about the last part of the hip bone, which is the what? Pelvis. Pelvis consists of three parts. It has a body and it has two rami. This is the body forming the anterior aspect, anterior medial aspect of the obturator foramen. Alright, while the superior ramus is forming a part of this acetabulum, then it has an inferior ramus also. So it has a body, it has a superior ramus, and it has an inferior ramus. Alright, so the body and the inferior ramus forms a part of the obturator foramen. So there's something I want to make mention of here. You've heard of ischiopubic ramus, right? Ischiopubic ramus is a combination of this inferior ramus of the pubis and the ramus of the ischium. That's why it's called ischiopubic ramus. So why is it important? When we'll be talking about the ischiopubic ramus, we'll talk about those subpubic angle and the rest. So we're going to make mention, we're going to come across this again soon. So those are the three bones that make up your hip bone. Alright, the question now is, what are the major joints? What are the major joints of this pelvic hip? But before we go into that, we are going to talk about the next bone, the sacrum. So this is the sacrum. Alright, this is the anterior view and this is the posterior view. You can see that it has here on the anterior surface, it has this ridge here called the transverse line. There's this line. You know that the sacrum is formed by 5 bones, 5 sacral bones, S1, S2 to S5. Alright, so these 5 bones, they fuse, and the remnant of the fusion of the intervertebral disc. Remember that vertebrae, they usually are joined by the intervertebral disc, right? But this forms a remnant. The intervertebral disc between adjacent sacral vertebrae, they form a remnant, and that will form what we call this transverse line. So this transverse line is formed by that remnant intervertebral disc. Alright, then if you notice, you have this foramina here. They are 4 in number. Alright, and then there's this important structure on the anterior surface, superior aspect, called the sacral promontory. Very important clinically, sacral promontory. Alright, and then you have the ala, sacral ala on both sides. Alright, when we divide this sacrum into parts, it has an apex, it has a base, it has a lateral surface. I would say you can see that in this lateral aspect you have this auricular surface for the articulation with the, I showed you on the ilium, the auricular surface of the ilium and that iliac tuberosity. So that auricular surface of the ilium, alright, and the iliac tuberosity articulates with the auricular surface of the sacrum. Alright, so that's what is seen here from the posterior view. It's not visible from the anterior view. Alright, it has an apex. So these are the major structures. Then there's something I want us to know here. There is this ridge formed here. We have the medial sacral crest, we have the intermediate sacral crest, and then we have the lateral sacral crest. What forms these crests? For the medial sacral crest, it's usually formed by fusion of the spinous processes of S1, S2, and X3. The first 3 sacral vertebrae fuse together, their spinous process fuse together to form the medial sacral crest. Alright, then for this intermediate sacral crest is usually formed by fusion of the articular surfaces of the S1, S2, X3 to S5 vertebra. Then this lateral is usually formed by fusion of the transverse processes of S1 to S5 vertebra. Alright, so these are very important. Then this sacral canal here, usually where the ends, the nerves that emit from the inferior end, the conus medullaris of the spinal cord, they pass through this area. Alright, so that's the importance of this sacral canal. It houses the nerves there. So I think that's it for these bones here. So the question we ask ourselves is, what structures make up the pelvic inlet and what structures make up the pelvic outlet? And that question we also ask is, what are the types of pelvis? Alright, that's another question we're going to ask ourselves. And that question we ask ourselves is, what's the clinical importance of this pelvis? We are just studying the pelvis. Why is it so important that we know about the anatomy of the bony pelvis? Alright, so before I go into that, we are going to look at the major joints of the pelvis. The major joints are usually the sacroiliac joint, which I believe you guys, most of you know, the sacroiliac joints, and then you have your pubic symphysis. Alright, so those are the major joints. So these are the major joints. The sacroiliac joints, there are 2 on both sides, and the pubic symphysis. Sacroiliac joint is a synovial joint. Alright, It permits limited movement, gliding and rotatory movement. So it's a synovial joint, alright, formed by the ali of the sacrum and the auricular surface of the sacrum and the auricular surface of the ilium. That's what forms the sacroiliac joint, right? While the pubic symphysis is formed by both iliac crest, the iliac crest of the pubis, the pubic crest, the pubic on both sides, that is the right and the left, they fuse together to form the pubic symphysis, which is a secondary cartilaginous joint. Those are the major joints. So the question now is, what are the associated ligaments to this joint? So I would like to show you guys that. Alright, so these are the associated ligaments to the sacroiliac joint. Alright, we have the sacroiliac ligament, alright, and there are three divisions. You have the anterior, you have the intermediate or the interosseous, and then you have the posterior. Alright, so this is the anterior, you can view here, the anterior sacroiliac ligament. Then you have the interosseous, which is not visible here, but if you look here, it's deep, it's found deep here. Then this one you see here is the posterior sacroiliac ligament. The one I'm showing this, the reason I'm showing this is because of this structure here we're going to talk about right now. This posterior sacroiliac ligament is going to extend downwards, down to the lateral aspect of the sacrum inferiorly. That is, it's going to extend to that area and form an attachment there. Alright, while this sacrotuberous ligament is also going to extend up, so they fuse together, alright, and they form these two ligaments. So both of them are having attachment with the lateral aspect of the sacrum inferiorly. Now you have this other ligament called the sacrospinous ligament. Yeah, why is it called sacrospinous ligament? It's extending from the sacrum to the ischial spine. Alright, so it's running laterally from the ischial spine to the sacrum inferiorly. So when these two ligaments intersect, they tend to form a foramina. Alright, they tend to form foramina, two of them. This greater sciatic foramen and this lesser sciatic foramen. So what forms the greater and the lesser sciatic foramen is formed by just sacroiliac ligament, the sacrotuberous ligament, and then your sacrospinous ligament, which is running laterally from the iliac spine to the lateral surface of the sacrum inferiorly. So that's major. But if you notice here, you have it anteriorly. This is sacrotuberous ligament, alright. So this is sacrospinous ligament here, and the one you see running downwards to the ischial tuberosity here is called the sacrotuberous ligament. So it's divided to form this greater sciatic foramen and this lesser sciatic foramen. So that's the major importance of that. So we've talked about the major joints. Then for this other joint, obviously it has associated ligaments too. Alright, it has a suprapubic ligament, which is not too visible. This one is the inguinal ligament. It's not too shown here, but it has a suprapubic ligament, and it also has an infrapubic ligament. Alright, so those are the associated ligaments to this pubic symphysis. So I would like to talk about some clinicals relating to the pelvic girdle. Alright, so there are types of pelvis we have. So I want to know if you guys can still hear me, so I don't just keep talking to myself. So can you guys hear me? I would like to know in the comment section below. Alright, you guys are really doing well. Alright, so we still continue. I'm feeling a bit nervous, but at least I've not done this some time now. So there are four types of pelvis. All right, so I'm going to talk about those 4 types of pelvis right now, and which you're seeing here. We have the gynecoid pelvis, android pelvis, anthropoid pelvis, and platinum pelvis. Why is that important? Because each, like a male, there's a pelvis that's found in male, pelvis found in female. There are some that are suitable for birth. There are some that females have that are not suitable for vaginal delivery. So that's the importance of knowing the type of pelvis. Alright, so that's the very important. So the question now is, what is the normal pelvis in female? Usually the normal pelvis in female is the gynecoid pelvis. That's this pelvis which usually having its pelvic inlet is usually round or oval in shape. Usually oval in shape. That's the usual shape of this gynecoid pelvis. Alright. So the common pelvis in females, that's to say the normal one is this gynecoid, but the common ones that you can find in females, it could be this gynecoid pelvis or this android pelvis. But when a female has this android pelvis, it's not suitable, it's very dangerous for delivery. And you notice that this pelvis is usually heart shaped. The pelvic inlet is heart shaped. So if a female should have this kind of pelvis, vaginal delivery is not recommended for that kind of person. Alright, they have to follow other approach of delivery, not vaginal delivery. Alright, so the question now is, what are the common pelvis found in female? The common pelvis that are found in males, they are usually these two. Alright, these two, the android pelvis and the anthropoid pelvis. Male, they don't give birth, so they can have any pelvis that don't allow childbirth. Alright, so their pelvis is android and anthropoid, which is heart shaped, and this is usually oval anterior posteriorly. Alright, then you have this pelvis called the platypoid pelvis. Alright, this platypoid pelvis is usually transverse in the is usually over in the transverse direction. There's a trick to remember this. Gynecoid pelvis just over, simple. Android pelvis heart shape, simple. Anthropoid pelvis, what happens? It's over, but it's in the direction of anterior posteriorly. Alright, simple. Platypoid pelvis, what is it? It's over, but in the direction of what? Transverse direction. That's it. So what are the major pelvis, common pelvis in females? This and this. Gynecoid pelvis and android pelvis. Alright, but the suitable one in male, the most suitable that is good for vaginal delivery is this gynecoid pelvis. Why? Because the pelvic inlet will allow delivery, easy delivery. But this guy will not. It's not too good. Alright. Why this anthropoid and this android is found in males? Then this is not too common. Alright, it's not too common. This platypoid pelvis. So what's the importance of knowing this? I've told you one is for determining if you can a mother can give birth via vaginal delivery. Another thing is also in forensic medicine. There are cases where let's say a plane crash and you have fractures of human remains around. What do? Those forensic anthropologists, what they do is to go to the scene, get these fractures, these human remains, skeletal remains, and then they put them together into a model, and then they check out for the shape of this pelvic inlet. So from the shape now, they can determine if that person is a male or if that person is a female. So you see, so that's why for those who are going to that area, it's very important that you know this. So that's the importance of knowing these types of pelvis. Alright. So that's one clinical importance of knowing your pelvis. Now let's talk about something else. Now we're going to talk about the diameters of the pelvis. Alright. Let me see if I have that diagram on it. Alright. These are the diameters. We have the anterior posterior diameter, we have the transverse diameter, and we have the oblique diameter. Alright, so this is it here, and this diameter has different values at different level. it has a value at the level of the pelvic inlet, it has a value at the level of the pelvic cavity, which is the lesser pelvis. It has, which is the cavity in the lesser pelvis. Don't confuse pelvic cavity with the lesser pelvis. Lesser pelvis is lesser pelvis, alright, the part of the pelvis below the pelvic inlet, while the cavity within that area that is housed by the pelvic surfaces of the hip bone, the sacrum, and the coccyx. That's what forms the pelvic cavity, that cavity there. Alright, so at the level of the pelvic cavity, you have this diameter different. At the level of the pelvic outlet, what forms the pelvic outlet? I'm going to talk about that shortly. I'll show you with the diagram, but let's talk about these diameters now. This anterior posterior diameter, you notice that at the level of the pelvic inlet it's 11, pelvic cavity it's 12, at the level of the pelvic outlet is 13. The secret there is just remember 11, 12, 13, right? It's increasing. So when it's going down, what is doing? It's increasing. Simple. Then this transverse diameter, what happens? Let's see when it's going down. When it's going down, what's happening is it's decreasing. 13, 12, 11. Then we'll talk about this oblique diameter. At the pelvic inlet, it's 12. Pelvic cavity, it's 12. There's no value for at the level of the pelvic outlet. So there are cases where they want to examine the diameter, alright? Because when let's say a mother comes in and wants to deliver, alright, and there's a need to examine to see if that delivery can be through vagina or CSS, alright. They have to check out if it's going to be through that way or via the different means, alright. So what do they do now? They're going to measure this diameter. The normal diameter they usually measure is the anterior posterior diameter. That is normal diameter, but they don't do it just directly, because the anterior posterior diameter is just extending from the posterior superior aspect of the pubic symphysis, alright. So let me show you that with a diagram that you understand. I think it's still shown in this diagram. It is usually extending from the posterior superior aspect of the pubic symphysis down to the sacral promontory, alright. It's extending to that level. But if you decide to put, because they usually use two fingers, alright, usually the index finger and the middle finger, the clinician inserts it into the vagina, alright. So if they should go directly straight, what happens? It's not going to be possible, because the urinary bladder usually lies here, just posterior to this pubic symphysis. So it has to follow an oblique direction, alright. So it's called the conjugate, true conjugate. So there have to be a measurement of the true conjugate diameter. So that's what is usually measured, and this is how they measure it. This is how they measure it here. Okay. So that you can see that that's how they measure it. But look at, they use both hands, They use both hands. So look at what they do. They get the index finger and they get the middle finger, and then you see that they are inserting. It's not going straight. If you notice now, the normal direction is usually in this direction here. Alright, it's usually in this direction from this area, this posterior superior area, straight down this way. Alright, it's supposed to be straight down this way. If you notice, right, it's supposed to be straight down this way, but now it's going in an oblique direction. This is true conjugate diameter. That's what it's going to measure right now. So when it inserts, it's going to, like normal, it's going to put the glove on, and then what it's going to do is this. It's going to insert both of those fingers into the vagina, trying to palpate the sacral promontory extensively, make sure that it's able to palpate the sacral promontory. But it's going to make sure that the other hand is lying inferior to that same hand, like it's as he's putting his hand, the other hand is lying beneath it. Alright, it's lying beneath it, such that that hand is going to serve as a landmark of the pubic symphysis. Alright, so when he inserts and is able to palpate the sacral promontory, what he does is to, once he gets to that level, he just immediately brings out the gloved hands, and then from there he measures the diameter, it measures the length from the index finger, not the middle finger. It measures the length from the index finger down to that second hand that is placed as the landmark for the pubic symphysis. So that diameter is called the true conjugate. Alright, it's usually the anterior posterior diameter, but it's the true conjugate because it's not the normal way it's followed an oblique direction. So it's the true what conjugate. The diameter is usually around 11 centimeter in length. So that's, you see that this vaginal this measurement is very important to know if a baby can pass through the pelvic the pelvic cavity. All right, it's going to pass through the lesser pelvis through the pelvic cavity. So it's very important to measure this true conjugate diameter. Then there are cases where this true conjugate diameter could be altered. That's another clinical we're going to talk about right now. All right, so this is my last point here. This last clinicals is called the spondylosis. Remember that your lumbar vertebra has different parts: body, transverse process, spinous process, or the articular surfaces, right? So there are cases where, and those transverse process, spinous process, the articular surface, all those structures form what we call the vertebral arc. All right, they are called the vertebral arc. So any of the structures from the vertebral arc could just break up. It could break up, all right? It could break up. You notice here that when it breaks up, this body tends to slide anteriorly, as in this case you see that it's sliding what anteriorly. So when it slides anteriorly, that's going to intrude into the pelvic inlet. You notice that normally this is how it's supposed to be. The baby is supposed to come out through here and then pass straight, but because it's protruding, what happens now? The baby comes in and what? Instead of going through here, what happens? The baby tends to what? May go in this direction. And if it tends to go in this direction, remember that it's going to be like this. I want you guys to understand the picture, not just explain it. Let me explain with this diagram. Alright, let me use this diagram. Okay, look at what I'm talking. Let's assume this lumbar vertebra is above, and you see that so you find your lumbar vertebra above, alright? Are you still with me? So you notice that when the lumbar vertebra, the fifth lumbar vertebra, usually the fifth lumbar vertebra, alright, when the vertebral arc breaks away, the body tends to intrude inwards into this pelvic cavity. Alright, it's going to intrude into this pelvic cavity, and usually the baby is coming down, the head of the baby is coming down and then flowing through this area down. But when it intrudes, what happens? If you can visualize, when it intrudes anteriorly, what happens? The baby will tend to follow that same curve and may get blocked. The head may get blocked. Alright, it may get blocked at this pubic symphysis. So if it gets blocked, what happens? That's a dangerous scenario. So what are the symptoms that you could tell that someone is having this spondylolisthesis? One can complain of tickling pains because the nerves get affected there. So when that lumbar vertebra tends to intrude anteriorly, what happens? It may affect the nerves that are running through the normal course. The patient complain of pain that is extending from it's coming from the pelvic region and then going to the thigh region. So those are major signs. So what do they do now? What you have to do as a clinician is to carry out MRI. Alright, is to carry out MRI, and when you carry out MRI, you're trying to look at the curve of the vertebral column. Normally the curve is usually following a normal contour. So there's this normal curve you find here, this concave curve. So if you notice now, it's not following the normal curve. This is the normal curve here. Look, this is the normal curve. And you notice that something happened. This particular L5 is intruding inwards. It's not, there's a gap here. You see this gap here, this gap here. You see normally the curve is this way. Alright. but now it's intruding inward, so there's a gap here. This is one sign of what we're talking about. All right, so notice here, if you notice here, you can see that it's like protruding away. You see that the curve is even prominent. You can see it. Once you carry the MRI, it's very prominent there. You can see that the curve is altered. It's supposed to be a normal curve this way, but it's altered here. You see that the L5 is protruding into the wall. It's protruding anteriorly. It's intruding anteriorly. All right, so it's going to intrude into the pelvic inlet. All right, so that's one thing too. So when the baby, let's assume the baby is coming, the head of the baby is coming, and what happens now? Instead of following the normal curve here, it may go this way, and it may get hooked somewhere. All right, it may get hooked in the pubic symphysis, wherever, and that's very dangerous. All right, so that's it. All right, in the absence of question, I think we should move on to the next presentation. There is no time. So I would like to call on the next presenter. Favorite, I think Favorite is online, right? All right, Favorite is online. Favorite is supposed to present on the anatomy of the heart. So Favorite, the session is open to you now. Thank you very much.
Yeah, good evening, everyone. So I'll be presenting on the anatomy of the heart. Can anyone hear me? Okay. So the heart is a hollow muscular pump which lies in the middle mediastinum. Like, this is our right lung. Can we see my screen?
Yes, we can.
Okay, the right lung and the left lung. Already we know that the mediastinum is located at the middle, like, should I say, separating the left lung from the right lung. So the heart is here at the middle mediastinum. This is the heart here. So and this heart has left side and right side. So this right side of the heart, it's receive polyoxygenated blood, that is the venous blood, and also it receives polyoxygenated blood from the body through the superior vena cava. These are superior vena cava. You can see the labia there, and the inferior vena cava, and it then pumps it through the pulmonary trunk and arteries to the lungs for oxygenation. So while the left side of the heart, of which I said we have the right side and the left side, the right side pumps polyoxygenated blood, while this left side of the heart, it receives well oxygenated blood, that is anterior blood, from the lungs, then through the pulmonary veins, and then pumps it into the aorta. This is the aorta. Pumps it into the aorta, then for distribution to the body. You can see this is the aorta. The left side pumps oxygenated blood, while the right side pumps the oxygenated blood, that is polyoxygenated blood, that is venous blood. So the next I will go to is the chambers of the heart. The heart has 4 chambers: the right atrium, left atrium, the right ventricle, and left ventricle. So the right atria, that is the left and the right atria, that is left atrium and right atrium, they are called the receiving chambers, which pumps blood into ventricles, that is the left and the right ventricle. And also the ventricle are the discharging chambers. So these are the 4 chambers of the heart. So the next I will talk about now is the layers of the heart. Let me use another picture. The layers of the heart. Okay, so The walls of each heart chambers, that is, they consist of 3 layers from superficial to deep. The layers are the epicardium, myocardium, and endocardium. Let me show us. Okay, yeah, the epicardium, you can see the inner part there, you can see the label there, that is the endocardium. Then the next layer after the endocardium is the myocardium, while the outer one is called the epicardium. Okay, so the endocardium is a thin internal layer, that is the endothelium and subendothelial connective tissue. They are the lining membrane of the heart that also covers the valves. Like we can see, let me show us a valve. Okay, yeah, this is the endocardium. They covers some valves, and also they are the lining membrane of which I said before. While the myocardium, they are thick. You can see this one, like the myocardium is thicker than the endocardium, so they are thick, and they are called the middle layer, which composed of cardiac muscle. We know the characteristics of, or the features of, cardiac muscle. So this myocardium, they compose of cardiac muscle, while the epicardium, which is the outer layer, is thin external layer. They are mesothelium. They are formed by the visceral layer of serous pericardium. So some textbook may say they are also called the visceral pericardium, but the layers of the heart, like they listed them out as the endocardium, myocardium, and the epicardium. So this epicardium, I said, is a thin external layer, that is the external layer. You can see the label there, and it's formed by the visceral layer of serous pericardium. So let's note this: the walls of the heart consist mostly of myocardium, especially in the ventricles. You can see that the walls of the heart, they consist mostly of myocardium, especially in the ventricles. Okay, so the next thing I'll talk about is the apex of the heart. Okay, this the apex of the heart, it lies at the posterior to the left fifth intercostal space, that is in adult. In adult heart, this apex of the heart, this apex of the heart is underlines the site where the heart beats may be auscultated, that is head on the thoracic wall, that is the apex of the heart. I told us it is located at the inferiolateral part of this right ventricle. So it is the part or the site where the heart beats may be head on the thoracic wall. So the next thing I will talk about is the base of the heart. This base of the heart is found mainly by the left atrium. This is the left atrium at this upper part. So this base of the heart, meaning the base of the heart should be there, it's found by the left atrium. Okay, with lesser contributions by the right atrium. The next thing I'll talk about now is the surfaces of the heart. This heart has 4 surfaces. It has the anterior surfaces, that is the sternocostal surface. It has the diaphragmatic surface, that is the inferior surface. It has the right pulmonary surface, that is the left the left pulmonary surface, the anterior surface, diaphragmatic surface, right pulmonary surface, and left pulmonary surface. Okay, so this anterior surface, that is the sternocostal surface, is found mainly by the right ventricle, while the diaphragmatic, meaning that is the inferior surface, is found mainly by the left ventricle. So it is the right ventricle, these are left ventricle. So the diaphragmatic surface, that is the inferior surface, is found mainly by the left ventricle, while Why the right pulmonary surface is found mainly by the right atrium. That is the right pulmonary surface. Why the left pulmonary surface is formed mainly by the left ventricle. Okay. Yeah, so the next thing I will talk about now is the borders of the heart. The heart has 4 borders also, like the surfaces. It has 4 borders: the right border, the left border, inferior border, and the superior border. So this right border is slightly convex. It's found by the right atrium. You can see it here, slightly convex, found by the right atrium, and is now extending to this is the superior vena cava and the inferior vena cava, extending between this inferior vena cava here and the superior vena cava. That is the right border of the heart. While the inferior border of the heart is nearly horizontal, like we can see this, which is found mainly by the right ventricle. We can see this right ventricle is like horizontal, lying horizontal. So that is the inferior border. It's nearly horizontal but not horizontal. While the left border is oblique or nearly vertical. So it's found mainly by the left ventricle and slightly by the left auricle. While the superior border, the last, is found by the right and the left atrium. This is the right atrium and this is the left atrium. So the superior border is found by these 2 atria. Okay, so note this: the pulmonary trunk, which is this is the trunk, is the continuation of the right ventricle. You can see the right ventricle. This pulmonary trunk is the continuation of the right ventricle, and it's now divided into right and left pulmonary artery. So the next I'm to talk about now is the chambers of the heart. Okay, like I said, I talked about the chambers already, talking about the right atrium, left ventricle, and the right ventricle, but I did not explain. So I want to talk about them now. Like I said earlier, the right atrium, it receives poorly oxygenated blood. That is the venous blood from the superior vena cava and the inferior vena cava, and also the coronary sinus. Okay, the right atrium, it forms the right border of the heart, of which we knew earlier, the right border of the heart, and it receives venous blood, which is the oxygenated blood from the superior vena cava and inferior vena cava. Another one, there is another chamber of the heart, the right ventricle. It forms the largest part of the anterior. This is the right ventricle. It forms the largest part of the anterior surface of the heart, and also it forms the diaphragmatic surface and almost the entire inferior border of the heart. So another one is the left atrium, which forms the base of which forms the base of the heart. While the left ventricle, it forms the apex of the heart. The right ventricle forms the apex of the heart, and the left atrium forms the base of the heart. So next that we talk about is the valves of the heart. The valves of the heart are structures that ensures blood flow in only one direction. They are composed of connective tissue and endocardium, that is the inner layer of the heart. So they are mainly 5 valves of the heart, which are divided into 2 categories. The intraventricular valve and the semilunar valve. So the intraventricular valves includes the tricuspid valve and the mitral valve, which is also called the bicuspid valve. So they are located between the atria and the ventricle. This is the ventricle, and this is they are located between the atrium and the ventricle. This is the ventricle. See the ventricle and the atrium. So that is where one valve is located. Sorry, the two valves, because the atrioventricular valves, the tricuspid valve and the mitral valve. So the tricuspid valve is located at the right atrioventricular orifice, while the mitral valve, which is also known as the bicuspid valve, is located at the left atrioventricular orifice. Okay, so the other valve is the semilunar valves, which includes the aortic valve and the pulmonary valve. The atrioventricular valve, it closes during the start of ventricular contraction, that is systole contraction, producing the first heart sound. That is the atrioventricular valve. It closes during the start of ventricular contraction and now produces the first heart sound, while the semilunar valve produces the second heart sound. Okay, so let me explain the tricuspid valve. It is located between the right atrium and the right ventricle, which I said. So it consists of 3 cubes, that is the anterior, septa, and the posterior. Another one is the mitral valve, which is also known as the bicuspid valve. It has 2 cubes. You can see the way it is there, differentiating it from the tricuspid valve. The mitral valve is also known as the bicuspid valve. So it's called the bicuspid valve because it has 2 cubes, while the other one is having 3 cubes, the anterior, the posterior, and the septa, while the mitral has the anterior and posterior cubes. So another thing, the mitral and tricuspid valves are supported by the chordae tendineae. They are attached also to the muscle called papillary muscles, which are located on the interior surface of the ventricles. So these muscles, they contract during ventricular systole to prevent prolapse of the leaflets into atria. Actually there are 5 papillary muscles. 3 located at the right ventricle and support the tricuspid valve. The remaining 2, they are located at the left ventricle, supporting the tricuspid valve. Okay, so another valve here we have to talk about is the semilunar valve. The semilunar valve, they are closed at the beginning of ventricular relaxation, that is diastole, producing second heart sound, of which I said earlier. The atrioventricular valve, it produces the first heart sound, while the semilunar valve produces the second heart sound. So there are 2 semilunar valves, the pulmonary valve and the aortic valve, of which I said earlier. This pulmonary valve, they are located between the right ventricle and pulmonary trunk. You can see the label there. This is the pulmonary trunk, and this is let me use the other video. Yeah, the picture, sorry. This is the pulmonary trunk, and this is the right ventricle here. So this pulmonary valve is located between the pulmonary trunk and the right ventricle. So another one is the aortic valve. It's located between the left ventricle and the ascending aorta. This is the aorta here. It's located between this and the left ventricle. So this aortic valve, it consists of 3 cubes, just like the way the tricuspid valve consists of 3 coops. This aortic valve consists of the right, left, and posterior coops, while the pulmonary valve also consists of 3 coops: the left, right, and anterior. Another thing I'll talk about now is the nodes of the heart. The heart has 2 nodes. I'm not sure. The heart has 2 nodes: the sinoatrial node, that is the SA node, and the enteroventricular node, that is the AV node. So the sinoatrial node, that is the SA node, is known as the pacemaker of the heart. So this pacemaker cells can generate electrical impulses, that is the action potential, and it's located in the upper wall of the right atrium. It's located at this part here. The right atrium, that is the SA node. While the AV node, it acts to delay the impulses. Okay, then to ensure the atria have enough time to fully inject blood into ventricles before ventricular systole. That's the function of AV node. The SA node, it generates impulses, while the AV node, it delays the impulses. Okay, so the next I'll talk about is the vasculation of the heart. The blood vessels of the heart, it's comprised of the coronary arteries and cardiac veins. The coronary arteries and cardiac veins, that is the blood vessels of the heart, which carries blood to and from the myocardium. This the right coronary artery. This supplies the right atrium. The right coronary artery supplies the right atrium, most of the right ventricle, right atrium, most of the right ventricle, part of left ventricle, part of the interventricular septum, the SA node, and the AV node. So while the left coronary artery supplies the left atrium, most of the left ventricle, part of the right ventricle, most of the interventricular septum, including the atrioventricular bundles, that is the bundle of ease. So, and also it supplies the SA node, that is the left coronary artery. So another thing I'll talk about is the venous drainage. Hope you can hear me. So the next thing I'll talk about is the venous drainage of the heart. The heart is drained mainly by veins that empty into the coronary sinus, and partly by small veins that empty into the right atrium. Another thing I'll talk about is the innervation of the heart. Actually, the heart is innervated by sympathetic and parasympathetic fibers from the autonomic branch of the peripheral nervous system. So that is the innervation of the heart. Let's see. The heart is innervated by sympathetic and parasympathetic fibers from autonomic branch of the peripheral nervous system. So the network of nerves supplying the heart is called the cardiac plexus. So it receives contribution from the right and the left vagus nerve. Let's see if that is the right and the left vagus nerve, as well as contribution from the sympathetic trunk. So these vagus nerve, they are responsible for influencing heart rate, cardiac output, and contraction forces of the heart. That is, the cardiac plexus, they are responsible for influencing heart rate, cardiac output, and contraction of the heart. So the next I will talk about is the clinical relevance. I will talk about the artificial pacemaker. Already I told us that the SA node is known as the pacemaker. So there is something called artificial pacemaker. It's used to correct heart rate and rhythm. So the most common indication for a pacemaker is bradycardia. Bradycardia is low heartbeat or rate. So once this artificial pacemaker is inserted, the pacemaker now monitors the heart rate and only fires if the rate becomes too slow. Already we know that bradycardia is slow heart rate. So when it's too slow, that is when this pacemaker, artificial pacemaker, then fires if the heart rate is too slow. So another one is the tachycardia. This tachycardia is rapid or fast heartbeat or beats. That is fast heartbeat. That is the tachycardia. So how the pacemaker works is it can also be used to treat some tachycardia, that is the fast heart rate, and also some certain types of heart block and other rhythm abnormalities. Okay, so how the pacemaker works, like I said, in bradycardia it fires when the heart rate is too slow. So in place of tachycardia, it now fires when the heart rate is too fast. So another thing I'll talk about is the aortic stenosis. Stenosis it means narrowing. So this aortic stenosis, it refers to narrowing of the aortic valve, restricting the flow of blood leaving the heart. So the main causes is actually age-related calcification, congenital defects, and so on. So this congenital defect, the congenital defect is mostly common in bicuspid aortic valve. Okay, so another thing I'll talk about is the myocarditis. So another thing I'll talk about is the myocarditis. That is inflammation of the heart muscles, often due to viruses. So the common abnormality of this myocarditis is the damage to the cardiac muscle of myocardium, and also it can now result to cardiac arrhythmias, that is abnormal rhythm of the heart, and also heart failure. So another abnormality I'll talk about now is myocardial infarction, that is heart attack, commonly known as heart attack. It's caused by a blockage in the coronary artery. And another one I'll talk about is the angina, which refers to chest pain. That is another abnormality of the heart. Another one I will talk about is teratology of Fallot. Okay. The clinical relevance, I said, artificial pacemaker, the aortic stenosis, that is narrowing of the aortic valve. The main causes is age-related calcification, congenital defects. Another one is myocarditis, that is inflammation of the cardiac muscle of the myocardium. Another one is the myocardial infarction, which I said is the heart attack, commonly known as heart attack. That is the myocardial infarction. Another one is angina, which refers to as chest pain. So another one is teratology of Fallot. Teratology of Fallot is a congenital heart defect in which there are 4 abnormalities found there. That is the teratology of Fallot. Okay, so with tetralogy of Fallot. The abnormalities found there are overriding aorta. That is when the aorta is connected to both the left and the right ventricle.
Alright. Viewers, we're impressed with your work. This is great content. Alright, I would like to call on the next presenter. I would like to call on Golden. So Golden, please, this section is open to you. Thank you very much.
Alright, good evening everyone. I'll be presenting on the thoracic diaphragm. Okay, please can you send in some messages if you can see my phone screen so I can start? Or Lawrence, just reply. Yes. Alright, thank you. So the anatomy of the thoracic diaphragm. Let's start with the introduction. The diaphragm is a double dome musculotendinous partition that separates the thoracic and the abdominal cavity. Okay, sorry for that breaking connection. The diaphragm is a double dome musculotendinous structure that separates the thoracic and the abdominal cavity. So this is a diaphragm. It's convex superiorly and concave inferiorly. So the convex part faces the thoracic cavity, while the concave part or inferior surface faces the abdominal cavity. So the diaphragm is the chief muscle of inspiration. During mechanism of breathing, you notice that in inspiration, they said the dome-shaped diaphragm contracts and flattens to increase the volume of the thoracic cavity. So let's go to the features of the diaphragm. So I've talked about the shape. There are different variations in the diaphragm. During some conditions or under some conditions, the diaphragm usually undergoes some variations. For example, during phases of respiration, in inspiration, it contracts and flattens, while in expiration, it goes back to the dome shape. Then your posture also determines the position of the diaphragm. On standing, the diaphragm is halfway. On sitting, it's at the lowest. That is why during, let's say, a patient with dyspnea, that is difficulty in breathing, the patient is usually asked to sit, because at that point, the diaphragm is at the lowest and there will be maximum ventilation. And then while lying supine, it's at the highest point. So let's quickly move on to the parts of the diaphragm. The diaphragm has the central tendon and the peripheral parts. So the central tendon of the diaphragm has no bony attachment. It's the mobile part of the diaphragm and is completely divided into three leaves: the right, the middle, and the left leaf. So the second part of the diaphragm is the peripheral part, which is the part close to the edge. Now this part is fixed. The peripheral part is fixed to the thoracic cage, the inferior margin of the thoracic cage, and then the superior lumbar vertebra. So just the central tendon of the diaphragm is the mobile part. The next should be the muscular attachment. The diaphragm has external muscular attachment. It may be present or it may be absent in some people. So this sternal part has two muscular sleeves that insert on the devoid process of the sternum. That's why it's called the sternal part. It's attached to the sternum. And then the costal part is attached to the inferior 6 ribs, the internal surfaces of the inferior 6 ribs. That's your 7th to 12th rib. Then you have your lumbar part. The lumbar part forms the medial and lateral arcuate ligaments that insert your L1 to L2 vertebra. Also the crura of the diaphragm, or it's also called the cross of the diaphragm or cruise of the diaphragm. So you have the right and left cruise of the diaphragm. The right one originates from L1 to L3 vertebra, and it forms the esophageal hiatus, which I'll talk about later on. Then the left cross originates from L1 to L2 vertebra, and it lies left to the midline. Okay. The next thing, I don't know. Okay. The openings of the diaphragm or the apertures of the diaphragm. The diaphragm has 3 openings or 3 apertures, which are your caval opening, your esophageal opening and your aortic opening. You can see them in the diagram on the screen. So the cable opening is the most superior aperture on the central tendon of the diaphragm. These openings, they have contents that pass through them, and for the cable opening you have your inferior vena cava, that's why it has a name, and then you have your right phrenic nerve. Going to the second opening, it lies at T10 vertebra, while the cable lies at T8. So the esophageal hiatus or esophageal opening is the second one, and it lies in the right cross of the diaphragm, which I've said before. It transmits your esophagus, the esophageal branch of your left gastric vessels, and then your right vagus. Yes, your right vagus nerve. Alright. Then the last opening is your aortic opening. It lies at the level of T12 thoracic vertebra. It transmits your aorta, your thoracic duct, and your azygos vein. This aortic hiatus lies between the right and left sclera, which are joined by the medial arcuate ligament. So the next thing should be blood supply to the diaphragm. The diaphragm has a superior and inferior surface. The superior surface is the convex surface that faces the thoracic cavity, and the inferior surface is the abdominal surface that faces the abdominal cavity. So the superior surface is supplied by pericardiophrenic and musculophrenic arteries. These are branches of the internal thoracic artery, and it's also supplied by the superior phrenic artery, a branch of the thoracic aorta. Then the inferior surface is supplied by your inferior phrenic arteries, branches of the abdominal aorta, or it might rise from the celiac trunk. Then the venous drainage of the diaphragm, it's similar to the arterial supply, just this time is veins. So the superior surface is drained by your pericardiophrenic and musculophrenic veins from your internal thoracic veins. It's also drained by your superior phrenic vein and then by your hemiazygos vein. While for the inferior surface, you also have the phrenic vein, and you have the right and left phrenic vein. So the next thing on the list is the lymphatic drainage of the diaphragm. So the thoracic surface is drained by your parasternal nodes, your posterior mediastinal nodes, and your phrenic lymph nodes, while your abdominal surface is drained by your phrenic nodes, anterior diaphragmatic, and your superior lumbar nodes. Innervation of the diaphragm. The diaphragm receives motor supply from your phrenic nerve, which has root value C3 to C5, and then sensory supply from your phrenic nerve also. The central tendon receives sensory supply from your phrenic nerve, while the peripheral part of the diaphragm receives nervous supply from your intercostal nerve, the 5th to 11th intercostal nerves, and then your subcostal nerve. So the last thing I'll talk about is the clinical correlates. So the first one, it's about the nerve supply of the diaphragm. It's supplied by phrenic nerve C3 to C5, like I've said before. This nerve also supplies the shoulder. So when there is, like, let me say, a rupture of the diaphragm or injury to the diaphragm, there will be referred pain to the shoulder. Instead of feeling the pain around the diaphragmatic region, you feel the pain on the shoulder. Then another important clinical correlate is your hernia. Hernia is the protrusion of abdominal contents into the thoracic cavity. So in the diagram on the screen, you can see normal hernia. In normal hernia, the stomach there, it's the stomach, the intestine, or the abdominal contents, they are still in the abdomen. But in sliding hernia, the cardiac end of the stomach moves into the thoracic cavity vertically, as you can see on the diagram. And then for the paraesophageal hiatal hernia, now note this hernia has occurred through the esophageal opening. So for paraesophageal hiatal hernia, from the name, the cardiac end and the fundus of the stomach, they move parallel to the esophagus. At the anatomy of the thoracic diaphragm. Any question?
Golden, what is the ventration of the diaphragm?
Sorry, I didn't hear you.
What is diaphragmatic eventration? Did you hear me? And then another question is, what are some congenital anomalies associated with the diaphragm? Did you talk about the cruise of the diaphragm and the foramina? I probably missed that. My first question was on diaphragmatic eventration. What is diaphragmatic eventration?
Good to have you guys around. I want to thank Golden, Favorite, Sylvester. So that will bring us to the end of this section.